are these patients with TR, are they just waiting to be found, or or are they already here, as you kind of describe in terms of the incidence and prevalence?
Yeah, they're here. The problem is we don't keep a memory of those. You know, you make the diagnosis, they disappear in your database, and you focus your attention on the patient who's here. So whenever you have a new therapy and you go to somebody, you say, okay, find me now a patient with TR, and they give you the guy who's going to die tomorrow with a TR. And they don't have a view. But when we look at our entire experience, there are a large number of patients who are affected by TR, but we have the impression that we can't do anything. So we put that under the rug, and we say, okay, yeah, moderate TR, so like don't pay any attention, and then I don't want to see this patient again. So I think that there is, we're trying to save ourselves in our practice by saying, okay, I can't do anything, leave me alone with this guy, and we're not assembling them. But with a new therapy, just like we had in AS, I'm sure these guys will come back and will be detected and treated. They are there, and we need to heighten our attention.
So, Becky, if I could ask you, so you've written a lot about quantitation. How much of this is a quantitation issue? You know, you described how we tend to calibrate our eyes to look at left-sided disease, and we're not quite calibrated to look at right-sided. Do you think we're underestimating the severity in our current studies, and would the incidence actually be much higher than what you describe if we were calibrated properly?
Yeah, I think it's a great question. And what we found is that because of the anatomy of the valve, which is that the septal and anterior leaflets are longer circumferentially than the posterior, the regurgitant orifice is between the slit-like orifice, and so therefore the PISA, which is the only quantitative measure mentioned in the guidelines or advocated in the guidelines, really can't describe, it assumes a circular orifice. Now, we would never throw out PISA because we have so much outcomes data related to PISA, but in part, you know, the outcomes data that Maurice had shown also earlier were 20 millimeters squared for the mitral, same on the tricuspid he showed. And so that 20 millimeters squared of regurgitant orifice from PISA really is a 40 millimeters squared if you quantified it. So it's roughly a 1.8 in general relationship of PISA to quantitative Doppler. And so we are definitely underestimating. And also we've relied very heavily on the quick and dirty. I mean, we've got a lot of, you know, clinicians have a lot of studies to read. They're looking just at color Doppler. You have to remember the right heart is a fraction of the pressure of the left heart. And color Doppler is driven by momentum. And so with the color Doppler jet area of 10 centimeters squared, which some people use to indicate severe, is 4 times as severe on the tricuspid side than it is on the mitral side. So we just have to reset everyone's thinking about tricuspid and how to grade it, and also reset the clinicians' referral patterns in as we get devices. So we still don't have an approved device to treat tricuspid regurgitation, but since we've been in trials for the last, since the SCOUT trial, really, our clinic meets, you know, our valve clinic meets twice a week, but typically we'll get about 5 new tricuspid patients a week. Wow. And so it's grown from like no tricuspid patients to 5 a week, and so I think it's just a re-educating the clinicians to send those patients forward.
Just the point that Becky makes on the difficulty with the TR is very important because, you know, MR, it's always high velocity jet. Mm-hmm. TR, it can be low velocity jet, and it appears like nothing. It appears like nothing. It's all blue because the force is not pushing the blood at a high volume, high flow. But when you quantify, you realize that there is much more than what you thought. And so there is much more opportunity for making a mistake in the low velocity range where we underestimate. We say, oh, it's no big deal. And then we do the hepatic venous flow and we say, oh, there is a reversal. How come? And so we have to pay even more attention to the tricuspid than to the mitral because of that issue of different pressure regimen.
So I think, these themes that you guys touch upon remind me a lot of what we used to say about secondary MR. Kind of low flow, low momentum, difficult to quantify, or, there are certain limitations, and then perhaps is it an association, or is it actually a real causative phenomenon? Then, when the co-op data came out, we said, oh, wait, it is actually causative and correctable, and it's a surprise to many people. But then there's all this discussion about proportional MR as well. And so is there a proportional TR concept that we need to explore? Is it association or actually causative? Is there a way of doing that? And Joel, would that be something you could look at with CT and MRI, looking at proportional, because you have the volumes and such at your disposal there?
Yeah, I think that's a great question. And what is the adequate RV adaptation to that volume? Right atrial adaptation to what Maurice is just highlighting, that when you see these patients, you don't see that jet. The right atrium is a very resilient chamber, that it dilates until it reaches the point of now I cannot, and then regurgitates. I think with the CMR and CT as well, it's been able to characterize that anatomy and see where do they fall into that natural history. We're very crude, and I think, as I highlighted, we underestimate consistently. And I would say that this moderate TR category is a very difficult one, because sometimes you look at moderate, depending on how you slice and dice, you say, wait a second, it's not moderate. So I would suggest us to have a lower threshold to get a TE or get it some more anatomical basis and say, hey, there is actually significant tricuspid dilation, and what I see here is actually not moderate. To be able to shift that pendulum a little bit earlier, because I think we are now seeing, obviously, we're still as a learning field, treating patients that obviously do not have other methods for surgical intervention.
I mean, I think, Joel makes a really good point also about the anatomy versus, using the color Doppler and things like that. I mean, we know that it is a very hemodynamically variable jet. And so even with respirations, we can see it be severe and then nothing. And so it's very preload, afterload dependent, but the anatomy itself is kind of all telling. So the dilatation of the annulus has been time and time again shown to be correlated with severity of tricuspid regurg. The tethering, the coaptation gaps, I mean, you all really showed beautiful coaptation gaps on CT, and obviously we can see them on 3D as well. I mean, those are coaptation, that coaptation area must have, malcoaptation area must have been well over a centimeter squared. Yeah. And so I think it's a tough valve to quantify, but I think anatomy becomes then very important. And the one other thing to ask Maurice is if I had to choose one quantitative measure for both the mitral or the tricuspid side, I might actually choose regurgitant fraction, because that gives you an idea for that particular ventricular output, cardiac output, how much is going backwards. So if 50% is going backwards, that's not a good thing, no matter what you might quantify as the actual volume of regurgitation. And so I think that hidden in regurgitant fraction is a lot of information that takes into account that proportionate and disproportionate.
It's a proportional way of doing it.
The facts have a tendency to sort of bother our assumptions. And I started exactly with the same question. And you say, okay, maybe the fraction is an important thing. And fraction doesn't beat the orifice. What is important is the starting point is how big is the orifice. Then if the patient is alive, they have to maintain the forward stroke volume. And so the regurgitant fraction flattens very quickly in functional MR, and I haven't calculated in TR. But so in our experience, and now in thousands of patients, we find that the most useful measure is the size of the hole, less the regurgitant volume, and less the fraction, because the fraction integrates what is necessary for the patient to be alive, but it doesn't tell you how bad this is. So, yep, I had the same instinct of saying, okay, let's check the fraction should be the best one, but in fact, no. They're highly correlated. It's, yes, fraction is useful, but if you have all of them, the size of the hole is what counts.
Steve, you have a comment? Yes. I was waiting when you would actually chime in.
So I have two comments. One, there's only one view of the tricuspid valve, that's the surgeon's view. The second thing, this is always an interesting discussion, like how much can we quantitate, how much is good, the right atrium can be, a volume capacitance, and if 40 cc's are going back. That's not how the heart is built. The heart is built to have zero regurgitation. If I polled everyone in this room and said, how much TR would you like to have? Everyone would say zero. Because that's going to be the best outcome. Now we can show the difference between putting 100 cc's backwards and zero. But I bet you if we had enough people in a big enough study, we could show the difference between 3 and 0.
Yeah, sure.
So our
Yeah.
goal should, whether it's proportionate or disproportionate or your proportionate or my proportionate, we evaluate things a little bit differently. What we want to have is a safe way to completely eliminate TR. And I think that's be a lot of the discussion. Obviously, I can operate on these patients, get a pretty good result, but the risk benefit of that has not been acceptable in a lot of places. So I think this is a great discussion, and obviously, but I think we have to think about our goal. What does the RV really like to do? It only likes to push forward.
Yeah. No, but you're absolutely right. When we have enough patients, and I showed that in our series of LV dysfunction, you see an effect of even mild TR, and then the moderate. There is that sort of increasing risk with more regurgitation, even with a crude judgment that you make at the end of your report. You're saying how much TR there is. It's absolutely true. What you want is to have trivial TR so you can measure the pressure and no more 3 red blood cells swimming against the flow is okay.
But I also think you mentioned something really important, which is risk-benefit. So if you have a mortality rate, an in-hospital mortality rate of isolated tricuspid valve surgery of 10%, 1 in 10 of your patients is going to be dead, then you start to begin to accept perhaps lesser or more tricuspid regurgitation following a transcatheter procedure where the mortality is 0. And so I do think that it still is going to end up being a risk-benefit analysis.
Totally. No, I think our definitions of severity are completely guided by the safety of our therapies. And that's historically, we saw that with surgery from AS, we kept, we've lowered the interventional cutoffs that we think about for AS. MR is going to be like that, and TR is going to be like that too. And the traditional definitions of severity are basically designed to govern when one should intervene based on the current risk-benefit analyses. And because surgery is perceived to be high risk, the cutoffs are a little bit high. But as therapies evolve, I'm certain that what's severe now, or what's mild now, probably will be described as severe in the future. It's my opinion. And intervenable. Yeah, Joao?
No, and I think, the point that Steve made obviously is very important. I would argue that some of these ventricles went into the far extreme, eliminating TR completely too, by a surgery or any other methods might not be so, ideal. And the reason being is that is still some afterload, that they can still pop off. These ventricles have been remodeled and beaten up by TR for several years. And as Becky said, if we can achieve some rep reduction, and you've shown with the Triluminate pivotal that even a reduction from one of those classes from torrential to massive, they still have KCCQ improvement. Yes, it's not ideal. We're not going to eliminate completely, but we are achieving that with some safety boundaries. And it's definitely a moving target.
So I have a question for y'all. Do you think we're masking severity of TR by putting patients on diuretics?
It's very dynamic. TR is very dynamic, so when you treat the patient, you decrease it, you reassure the physician, and that's one of the reasons for the patient being pushed aside, is okay, I treat you with diuretics, come back in 6 months, and in 6 months maybe the patient is dead. So you don't have a clinical problem anymore. And so yes, we do that. There is that decrease. You're satisfied, but a month later, 2 months, 3 months, it's going to be back. And so we have to be very attentive in that reaction to say, okay, I have a very defined time of medical treatment, and I want to see you relatively early because it's a high-risk situation.
I think you're also pointing to, you know, some of the gaps in our knowledge. We can't just rely on symptoms. There have to be other markers that we should be able to identify that would allow us to say these patients are at higher risk. So, you know, a BNP equivalent for the right heart, because once the BNP goes up, then, you know, you're pretty sick. But there must be other markers, other ways. I mean, we've been toying with looking at liver stiffness and other earlier markers that will tell us that even though they've responded to diuretics, now is the time to intervene and prevent further deterioration.
I mean, I just think of the left side. If we had a DMR patient, we wouldn't use diuretic response before deciding to go to surgery. We would decide there's a mechanical orifice problem, and we would correct it. And I just worry that with tricuspid regurgitation, we're making the same mistake, and probably even more so because the RV is so preload dependent, and TR is so preload dependent that we can easily mask patients who actually have underlying TR that's just indolent and sneaking up on them.
That's why I think we should also consider adding the anatomical characteristics, because if you have a tricuspid annular dilation tethering, it can look great that the TR has reduced and the patient feels better, but the anatomical substrate still is there. And it would not, you know, take too long for this TR to come back again. So it gives a false reassurance, I would say.
And the important thing is that the patient be referred to a heart team, to people who know what they're doing, because you have general practitioners seeing the patient. They're really good and important, but in 10 minutes of a visit, you cannot make a decision that incorporates the comorbidity, the age of the patient, the operative risk, and people don't come back in great part because the echo reports are made to the general practitioner, and they don't have a way of referring the patient to a heart team to say, okay, we're going to weigh the risk of this patient. So what we have is to attract the attention to, in the general practice, to the general practitioner so that they don't sleep on a moderately severe TR and say, okay, oh, it's not major, so I'm going to wait. This guy is 75-year-old. He doesn't need an operation. A decision made in 1 minute without really observing the patient. And so the important thing is to say, okay, when you have this kind of report, either we have an automatic system to detect the patients and get them to the heart valve clinic, or you have a system of referral to get the patient to a heart team to see the patient with a surgeon, with an interventional cardiologist to say, what can we do? And there's going to be a number of people where we cannot do something, but I'm sure that there's going to be much more intervention because these people come before they are in intractable heart failure. Intractable heart failure, this is what causes the 10-15% operative mortality. And so we have to get out of this vicious cycle of the intractable heart failure.
I'm going to say that alert system should be for moderate TR.
Yeah.
Even it should not be just for severe. It may be even mild moderate TR if that's described. Joe, you have a comment?
I think so. I think if you have moderate and you have right atrial dilation, go for another method to confirm where you are, and from there decide. And we know that these patients, the most common symptom is actually very nonspecific fatigue. I mean, they just don't feel the same. They feel unplugged. They feel like they don't have stamina. And then you go back and say, oh, there was severe TR actually going back 2, 3, 4 years ago. And now they present with right-sided dysfunction, and it was missed, it was undercalled, and et cetera, et cetera. This is such a common theme that we need to do a better job and have an alert system, as you said.
Fantastic.